Today we are going to discuss insulin signaling and mitochondria, a new cellular target. We all know that the receptor signaling is the key in glucose gate opening. And there is a new class of molecules called glimins, which are likely to be launched soon, which fundamentally work through insulin signaling and mitochondria. We all know that people living in India have a very rapid early macro and microvascular complications, and they have an early progression of the disease. And therefore, there's a call for early action. We have early onset of type 2 diabetes. They are coming around 2 decades earlier, and they present often with complications. The biggest clinical challenge in management of diabetes is the impact how the current treatment approach impacts the macrovascular disease, not the microvascular disease. And therefore, in long-term follow-up, which we have of 30 years of UKPDS, we clearly recognize that. We know that diabetes-related complications appear early. They accumulate rapidly within microvascular group in more than two-thirds despite of background metformin therapy. And that is a very well-documented thing. So why is the mitochondria becoming the focus or the heart of type 2 diabetes mellitus? We know that if you look at the beta cell dysfunction, if you look at the hepatic or the muscular glucose reuptake or the hepatic neoglucogenesis, the typical triad, what is at the focus or the heart of the matter is mitochondrial dysfunction and mitophagy. So clearly we know that type 2 diabetes is a chronic metabolic disorder with metabolic dysfunctions. There are genomic issues in mitochondrial DNA, there are DNA mutations, there are polygenic variants. We have environmental factors like intrauterine malnutrition, environmental pollutants, and obesogenic environment and obesity. All of them stun the mitochondria and cause mitochondrial dysfunction, which in turn will result in beta cell dysfunction, where there is abnormal fusion, fission, autophagy of the beta cells, apart from impaired insulin secretion. But more importantly, mitochondria halts and makes the insulin signaling inappropriate. And that is the core defect of insulin resistance, where there is a downregulation of mitochondrial DNA, downregulation of oxidative phosphorylations, and upregulation of the bad end products like DAGs, the ceramides, the LCACs, and ultimately the end result is type 2 diabetes mellitus. So in the metabolic dysfunction triad of beta cell dysfunction, hepatic lipo and gluconeogenesis, and insulin resistance, clearly we see that mitochondria is at the heart of the matter. Because we know that mitochondria catalyzes an energy gradient across the respiratory transport chain, complex 1, 2, 3, 4, and 5, which mediate insulin secretion and mediate insulin sensitivity. So if you see the complex 5 here illustrated in this diagram, you can see the beta cell secretion and insulin secretion and smooth muscle insulin sensitivity. Fundamentally, there is inflexibility. So what is mitochondrial inflexibility? It is a dysregulated energy substrate metabolism of the mitochondria. Healthy mitochondria allows efficient functioning of the liver and the skeletal muscle, the pancreas, and the cardiac tissues. And there is an alternative switching between glucose substrates or pyruvate. This alternative metabolic fuels is lost when we accumulate a lot of ectopic fat and become obese, or we eat too much of carbohydrates. And eventually, when there is diabetes, obesity, or type 2 diabetes, this ability of mitochondria to switch the metabolic fuels is lost. That is the crux of the matter. That is the heart of the matter. And that is called as mitochondrial induced metabolic inflexibility. So obviously, when you have a fast state or a fed state, there is a ability of the substrate like free fatty acid or glucose to switch oxidation and acetyl-CoA. And that acetyl-CoA creates an energy gradient with NADH, which is responsible for cellular energetics, which mediate insulin sensitivity and insulin secretion with an increased ATP-ADP ratio. But what happens in type 2 diabetes or adiposopathy or adiposity-based chronic metabolism and DBCD is the glucose substrates are downregulated. There is excess glycolysis and gluconeogenesis. There is a diarrhea of free fatty acids. And all that allows the fuel substrates to go in excess to cause an oxidative environment of stress that will upregulate acetyl-CoA and reactive oxygen species, which will lead to acetylation, and the signaling at cellular energetic level is impaired. because of down regulation of ATP to ADP ratio, and both insulin secretion and insulin sensitivity is impaired. So therefore, now why are we talking about this? We are talking about this because we have a molecule which is similar to metformin. You can see the metformin structure here, which has a dimethyl group, the fenformin structure, which has a phenyl group. And now we have a trizene compound which has a bigunite substructure similarity with metformin. A trizene compound with bigunite substructures with similarity of metformin is imiglivin. And this imiglivin possesses 2 carbon atoms with cyclopentane ring. This imiglivin possesses 2 carbon atoms with cyclopentane rings, and structural similarities and differences suggest that there are complementary effects of mitochondrial respiratory chain as well as C1 and C3 with improved cellular energetics. So clearly we recognize that. So remember, imiglivin is a first-in-class molecule. It has been terminologically named by WHO as an indication for type 2 diabetes management. It is a very well-researched molecule in Japan and China, approved in Japan in 2007, approved in China in 2021. It fundamentally works through 3 pathways: impaired glucose uptake by muscle tissue, excessive hepatic gluconeogenesis, increased beta cell apoptosis. And therefore, in various clinical trial programs like times 1, times 2, times 3, in type 2 diabetes mellitus, both naive and uncontrolled, you can do that. So where does imiglivin work? It fundamentally works through NAMPT, NAM and NAT. So basically the nicotinamide is moved to nicotine and NAD, which is a salvage pathway in insulin signaling pathway. Also, it works on the ATP to ADP ratio and the amplification pathways inside the insulin signaling apparatus. Thereby, the CD38 will get into a pathway where the lysosomal and calcium upregulation will make the beta cells more efficient to secrete insulin, as well as it will open up close the potassium channel and cause membrane depolarization. So imiglivin modulates the mitochondrial chain complexes C1 and C3. They improve insulin secretion and sensitivity in the pancreas and smooth muscle at the C1, the C2, the C3 pathway. Clearly, we know that at each level, at number 1 ATP to ADP ratio, number 2 the NAD, number 3 the potassium ATP channel, number 4 the calcium flux, and number 5 the insulin release. The NAD synthesis complements C3 activation for calcium flux mediated insulin release. So the NAD metabolism is now the new target for cardiovascular death associated with sudden cardiac death. We are seeing suddenly a spurt of cases where people are just dropping dead. And we know and we recognize that NAD synthesis and metabolism re-energize the cardiac mitochondrial respiratory chain complexes 1 to 5, demonstrating moderate clinical effectivity on mortality reduction in coronary artery disease cases. So clearly, imiglivin amplifies cellular energy pathways in insulin sensitivity by upregulating the insulin-resistant-like substrate activity or the ATP to ADP ratio. They downstream signal the PA13 kinase and AKT with improvement of nitric oxide. They correct the endothelial dysfunction, improve cellular energetics and blood force sensitivity, and glucose transport and insulin sensitivity. So clearly, you can see imiglivin is a mitochondrial re-energizer. It downregulates the C1 and reduces reactive oxygen species and oxidative environment. It can clearly cause the modulation of cardiac energetics and re-establishes the equilibrium of NAD by improving the insulin secretion. And it upregulates the C3 RTC, where the insulin sensitivity and secretion has been improved. So whether it is the mitochondrial bioenergetics, whether it is the liver fat oxidation upregulation and downregulation of hepatic glucose production, whether it is the modification of making physiological secretion of insulin from the beta cells, or whether it is a glucose uptake by the muscle, at each step, imiglivin has a cellular energetic mechanism. And when you compare it with other agents, it drops the A1C by around 1% through this unique mitochondrial pathway. And clearly, head-to-head with metformin versus sulfonylureas, imiglivin impacts the electron chain pathway, the NAD salvage pathway, the potassium ATP channel closure which sulfonylureas do. It causes insulin secretion by improving the beta cell dysfunction. It inhibits hepatic gluconeogenesis and improves insulin sensitivity. So it actually is a perfect mixture of metformin sulfonylurea with complementary actions of both and more. Times 1, times 2, times 3 are trials as add-on which have been done for its approval way back, almost 4 years back, which have been published in journals like Diabetes Care, where clearly it has shown it's a perfect add-on to metformin when added and can cause a very unique ratio. It's also been studied for safety and efficacy as an add-on therapy of people not controlled well with sitagliptin monotherapy. And here you can again see that with imeglimin, clearly there is a very good documented data published in good credible journals that it has a very low treatment adverse effects and it's quite safe. So whether it is times 1, whether it is times 2, whether it's times 3, 1000 milligram of imeglimin twice a day has been having the trials done in Japan. And it has met all the endpoints in a double-blind randomized controlled fashion, which has been anticipated and expected. Clearly, they also improve the proinsulin to insulin ratio, the proinsulin to C-peptide ratio, and they also upregulate the various insulin resistance markers like HOMA-IR, HOMA-beta, and QT1. Clearly, this novel glimmin oral antidiabetics has very good efficacy and safety profile in type 2 diabetic patients. And when you see the long-term studies also, the intensity of GI adverse events are virtually negligible compared to metformin. And it has a year data also, where it has shown that the A1C can drop up to almost a 1% as add-on therapy and has been consistent in double-blind randomized control studies over a period of time. And the Japanese data also shows versus insulin also, it can be very well combined and a significant drop of both lipids and fasting blood glucose can be seen. Also, it is insulin sparing. The times 3 RCT from Japan showed that a decrease of insulin dose can occur with imeglimin treated patients. And when you look at the glycemic profile with CGM, and this paper has been published just this year, if you add this imeglimin, the time in range will improve from 65% to almost 80%. And that's a substantial improvement. And you can see that the various CGM parameters like time in range, time above range, time below range are favorably affected by imeglimin. Also, the systematic review and meta-analysis of all the RCTs from Prisma identifiers in a very methodical way has been done of imeglimin. And clearly you can see that it addresses A1C and fasting, both in treatment naive and uncontrolled cases, addresses A1C and fasting, both in treatment naive and uncontrolled cases, and has an extraordinary safety profile, apart from maybe hypoglycemia, headaches, upper abdominal pain, vomiting, and diarrhea. So it's a first-in-class agent. It's a dual-acting oral anti-diabetic agent. It has a novel mechanism of acting on insulin sensitivity and secretion, modulates cellular respiration or oxidative phosphorylation at mitochondrial complexes C1 and C3, improves insulin secretion and sensitivity in pancreas and smooth muscle, amplifies NAD salvage, and has a very strong insulotropic action, 24/7 documented by CGM, and reduces the harmful proinsulin to insulin ratio, improves beta cell function, protects from beta cell apoptosis, modulates blood glucose effects by improving beta cell function, liver gluconeogenesis, and muscle. 8 RCTs have been done over a large population in treatment naive and uncontrolled populations, where it has been documented to be safe, well tolerated, and will be a perfect add-on to the currently available agents. Thank you very much for a patient hearing.